know we've talked a lot about procedures, and that's where a lot of doctors face the scrutiny. And so I know we've focused a lot of that here in this interview, because you have made such great advances. Most of the patients you deal with are those patients that have been told amputation, and you're trying to prevent that amputation. But I'm glad that you have brought us back to the medicinal therapy, the pharmaceutical therapy. You've brought us back to the patient's responsibility, the smoking cessation, the walking, the dietary changes. And I'd love for you to, because I know several of my patients have come your way, and your team has had such powerful conversations with these patients to say, this is your responsibility. So pretend I'm a patient. How do you talk to me as a patient to say, you know what, you got to walk, walk, walk? Why do I need to walk, walk, walk?
Sure. So our first thing that we tell our patients is that you have a life-threatening disease. It's affecting more than just your legs. And we're going to do all that we can to get blood flow to the legs. But the long-term outcome is going to also depend on you. Okay. We know certain things to be very important. We must control your cholesterol. You must quit smoking, not decrease, quit, because any cigarette smoke increases the likelihood of clot and spasm. And so you must quit. You must walk. And the reason that we walk is as we walk, if there's any element of the blood, of not getting enough blood to the leg, our body goes into a process that we call angiogenesis, where it helps to build collateral blood vessels to the legs. And so often if a patient just simply has pain in the legs when they walk, pain in the muscles, if we can have that patient walk a lot, they actually improve the blood supply to their legs. And that can be all the therapy that's needed. And we often try that first. In fact, we usually try that first in people who just have claudication or pain in the muscles when they walk. However, if they have critical limb ischemia, that's a different animal. We don't start with a walking program. We clearly tell these patients once we get blood flow, we want them walking. But right at first, particularly if they have ulcers that are non-healing or gangrenous changes of the skin, the trauma of walking may be somewhat harmful to that patient and healing that initial issue. But we tell patients that we're a team, and part of that team is them too. It's all the healthcare providers that we're putting in, but that their role is very important. They have to not just go to the drugstore and get their medicines, they have to take them. That it does no good to say they have the medicines and not take them, that they must quit smoking, that they really need to follow all of these other areas. And we really get a lot of buy-in. You know, national statistics talk about 20% smoking cessation. We're somewhere near 80% in our conversations with these patients of getting them to quit smoking and through this initial area. I think, you know, unfortunately, it takes extra time, but fortunately, we're willing to do that right now. And I think it's a very, very important part of patient care. One of our basic tenements of our mission statement was communication by word and deed. And, you know, patients don't go to medical school. Many don't read, you know, the latest articles. They don't see that. And all too often, they're spoken to with words they don't understand. Just as soon be showing them hieroglyphics and ask them to read it. It's not that. What we have to do is we have to be able to truly effectively communicate. And I think it's one of the lost arts of medicine is we've transitioned more and more to pure science. We have lost some of the art of medicine. You know, the older doctors took the time to sit there and talk with the patient. They made house calls. They did things where there was touch. But you know, that doctor couldn't pull a CT out of his pocket and make a diagnosis. That doctor couldn't get an MR at that patient's home. That doctor couldn't do an EKG at that patient's home. You know, yes, we've advanced tremendously scientifically, but in terms of psychologically how we deal with people, which is also very important in touching patients and making them have faith in us, we've probably gone the wrong way. And I really work hard to try to effectively bond with my patients, to make sure that they understand I'm working to try to help them, that I'm going to do everything I can, and that I do care about their outcome. And I think when you do that, you form a great bond. I have been blessed through my career of having great bonds with my patients, and I would never change that.